You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Dr. Kevin Boyd. We're going to be talking about Darwinian Dentistry. Dr. Boyd's a board-certified pediatric dentist with over 20 years' experience. I'm not sure what Darwinian Dentistry is, but we're going to get into it. So, Dr. Boyd, thanks for being here.
Hi, Darwinian Dentistry is just a cute little alliteration that describes a new educational framework that started about 30 years ago in medicine, and it was called Evolutionary Medicine or Darwinian Medicine. And I was really impacted by the creators of that, George C. Williams, who's an evolutionary biologist who's no longer with us, but Randy Nesse is a psychiatrist. At the time, he was at the University of Michigan, and he partnered with George C. Williams. And let's start looking at modern diseases that seem to be a function of cultural industrialization, and start analyzing them from not just proximate cause, which would mean like a fever. What is the proximate, immediately understandable main cause of a fever is pathogens entering the bloodstream. Well, that's proximate cause, but it doesn't really tell you much about why we get fevers and how is it that the process of natural selection, which is, the term that they use to describe how our ancestors were able to adapt over geological time to gradually but always changing environments. And when maybe a random mutation or something called genetic drift, but would confer a trait to somebody that would actually enable them to be better adapted to the environment, that's something that would get incorporated into the genome. One of the things that happens in mammals is that they get fevers when pathogen enters the blood, and if they survive the fever, they will live another day and hopefully reach the age of reproduction so they can pass on their genes. That's called evolutionary fitness. So
right.
The fever mechanism is what we, looking at fever from an evolutionary perspective means that we're looking why natural selection has allowed something as miserable as a fever to persist, and that's because it can confer evolutionary fitness to an individual. Well, how about tooth decay? How about malocclusion, or the why we need orthodontists? Like, what does that have to? When did that first enter into the human condition? So I've sort of adapted the model of evolutionary medicine or Darwinian medicine to evolutionary oral medicine or Darwinian dentistry. So that's where it comes from.
So any conclusions? Where do you think that, I would think most people would, I guess, say it's, at least for modern conditions, it's obvious, maybe poor eating habits leads to tooth decay and then maybe subsequent heart conditions or diabetes, things like that. I mean, what interesting conclusions are you drawing from this perspective?
Well, first of all, their conclusions, I don't know. There's testable hypotheses, but until we invent a time machine, we can't really go back in time, right? But we can. There's inferences that we can look at a 3,000-year-old human skull, and we can infer what the brain size was, even though soft tissues like brains don't really fossilize. But you measure the house within which a brain lived, and that is the skull, right? The cranium. So we just, in the early on in this science of anthropology, they would pour little metal beads or sand into a skull and, measure the volume, and that would be the brain volume, right? Well, you can do the same thing with jaws, in that we can measure the width of the jaws and the depth of the palate and the length of the jaws, and you can pretty much know what the size of a tongue was, because the tongue had to live up in the roof of the mouth in order to confer the ability to survive childhood and live to adulthood, because that meant you were a habitual nose breather, which is something that is just not really discussed much in medicine and dentistry now, as it was 100 years ago. So some of the conclusions are, like I just gave you one, but it's really not a conclusion. It's a hypothesis that has a lot of support. For any hypothesis to be valid, it has to be, refutable and testable. So we've come up with certain assumptions or suppositions that our pre-industrial ancestors, that is, living before cultural industrialization in Western Europe in the late 18th, early 19th century, and even today, you have Aboriginal cultures that they lived the same way they did for hundreds of thousands of years, and then they move to a big city, and they all of a sudden start getting, crooked teeth and cavities. So go figure. So that's really the main thing that we're doing at the Penn Museum, where I'm doing some postdoc research with Mariana Evans, who's a dual-trained orthodontist and periodontist at Penn and in Philadelphia. And what we do is we take these pre-industrial skulls, and that means they're at least 250 years old, right? When they die, it could be a 4-year-old that died, in the 1700s. It could be a 32-year-old that died, in 1850. Those are considered pre-industrial skulls. And we use three-dimensional radiography cone beam technology from Dr. Evans' private practice office. We take the skulls out of the museum, and we measure all the lines and angles that orthodontists use to decide how to treatment plan a kid or an adult that needs orthodontia. Does that make sense?
All right. So, yeah, what do you? Well, again, you're looking at historical skulls to see how people were physiologically, morphologically versus now, or are you applying this in a modern way somehow?
Yeah, we are. And that's a really good way you phrase that, is that, like I alluded to, a 35-year-old who say died, 2,000 years ago. Well, I can pretty much predict within a really strong degree of scientific certainty of what that 35-year-old looked like when he was 12, and what he looked like when he was 6, and what he looked like when he was 4, and what he looked like when he was 2. Now, how can I do that? Because you couldn't with a 35-year-old today. Like if I saw a 35-year-old with perfect teeth, erupted wisdom teeth, beautiful jaw, big airway, I couldn't really predict what he looked like when he was 3 years old, because maybe he had orthodontics to get that. Maybe he had surgery. Well, there wasn't orthodontics and surgery. If somebody didn't have perfect teeth in early childhood, they did not survive childhood, because perfect jaws and teeth, and that just means optimal for nose breathing habitually, that means that person prehistorically survived childhood. They couldn't have survived childhood, and it means that they were breastfed on demand for about 3.5 years and were weaned onto firm and unprocessed foods. They were papoosed on their mother's back. They had to hold their head up. They talked with a click language in Africa, which pushes the tongue against the roof of the mouth in early childhood. If kids couldn't do that, they didn't survive.
Really? Click language does that? Huh. Like causa?
Oh, yeah. You should. There's studies that lingual anthropologists do. They measure the pressure that a tongue creates when they push it to form the consonants that click languages do. So that's that's a hypothesis. I can't say that that's 100% true, but it's a testable hypothesis. So
that's cool.
From click speaking, from weaning onto hard and unprocessed baby-led weaning, it's called, breastfeeding on demand, for 3.5 years. Those are in papoosing, having to, hold the head up and keep the lips closed. The posture has to be really good. That confers survivability beyond childhood to a kid, in a pre-industrialized culture.
But currently, why, you said you couldn't tell if someone had all the right attributes today. I mean, what about medical records or questionnaires? Couldn't you ask them and, figure it out that way?
Well, for one thing, malocclusion isn't something that really the orthodontic profession, much less the medical profession, pays attention to till after the age of 7. The American Association of Orthodontists says a kid should not be seen or, should have their first orthodontic evaluation by age 7. Well, that's a geriatric patient in my pediatric practice. 7 is getting old. So there's so much that can be done in the preschool years. And I can show you published evidence from the late 1800s through 1940 that physicians and dentists were treating kids as young as 2.5 years old for orthodontic expansion, not to make their teeth straight, but to give them room for their tongues so they can breathe through their nose. The titles of the articles from JAMA, New England Journal of Medicine, when it was called the Boston Medical Journal, and Boston Journal of Medicine and Surgery, about how to improve a child's ability to breathe through their nose by orthodontic expansion. It's all over the place. Every lecture I go to now, I show more articles about this should be done. It's ridiculous that orthodontists don't want to see a kid till 7. It's medically indefensible, actually, because children who have restrictive traits in their jaws affects their airway. We don't call it craniofacial anymore. We call it craniofacial respiratory. And the hard and soft tissues of the craniofacial respiratory complex can give indication of a child's ability to breathe through the nose as early as, 18 months old, perhaps even in utero. On ultrasounds, we can pick this up. Yeah, so lots been happening, and there's a lot of support for it. Orthodontics, the orthodontic profession is being pushed to be seeing kids much younger. The American Dental Association House of Delegates just passed a resolution to support that people who see children in dental offices, whether they're pediatric dentists, orthodontists, or general dentists, they should be assessing airway risk and the shape of the jaw and the face. And this is big. It's the biggest thing since fluoride that the American Dental Association has gotten behind in terms of introducing new services.
So people in the dentistry world, sure, they know about this, but regular folks, it's a different story. So a typical parent.
I disagree with your premise. People in the dentistry world don't know about this. They did know
it's even worse. Okay.
Or two, but they're starting to. And the American Dental Association is way ahead of the curve on this, but it does not reflect. This is so new to so many people in dentistry. I think there's over 200,000 members of the American Dental Association, and I would hazard a guess, and it's just a guess, that probably 2/3 to 3/4 of all dentists don't understand this importance of assessing risk in the dental office, because most of the traits that are indicative that a kid may be at risk or already have existing airway disease are above the clavicles. It's definitely in the purview of dentistry, but there's not enough people that are really qualified. Pediatric dentists there's not enough of us to meet the demand just for tooth decay. And then when you start entering malocclusion and sleep and breathing hygiene, we're grossly outnumbered. We have to get more general dentists involved in this, is my contention. I think they're going to save the world.
I believe you, but let's, again, for the layperson and for someone that's not in your particular sphere, I can see them saying, well, why would I bring my child that's 2 to the orthodontist? I would think they can only think of braces. So what are the reasons why parents would bring their child into the orthodontist at such a young age? What kind of things can happen?
I'm not an orthodontist. I'm a pediatric dentist who almost does exclusively orthodontics on kids under the age of 7. So it's most pediatric dentists are not comfortable doing this type of early and aggressive expansion on 2, 3, and 4-year-olds, but they are very comfortable managing anxiety in kids relative to the need to fill teeth. All right, with injections and drills and things like that. And there's a certain amount of anxiety that's definitely intrinsic to providing orthodontic care at any age. Well, most orthodontists don't get any training in managing anxiety in kids because it's not expected of them and taught to them in their training that you should really at least be evaluating 3 and 4-year-olds, much less treating them. But general dentists, they represent a whole new cohort of providers. Now you say, well, the layperson, they have expectations. They didn't get braces till they were 13. And I get that from a lot of parents. Like, what do you mean you're going to do orthodontics? But when they see that when you do expansion and the evidence that exists for it in the literature before World War II, parents get it easier than most healthcare professionals get it because they've got their own expectations based upon their own experience with orthodontics, when they were kids, and much less what the orthodontic profession is teaching the public is that, get seen by 7, but don't get treated till between 9 and 13, which is really the vast majority of treatment. So it's easy to really override those expectations because they're parents and they have instinct. And when you start showing them pictures of kids, when you widen the jaw, you widen the airway, and then you show them evidences of kids doing better in school after they get expansion, stop wetting their bed. There's a lot of behaviors that are indicative that the kid is having trouble breathing while they're sleeping. And it's in the public domain now. In fact, there's an online magazine called Medium. I don't know if you've heard of it, Medium. I mean, if you Google, they just did a reporter.
Sometimes I read their posts. Yeah.
Yeah, well, Catherine Lewis is a reporter for the Atlantic Monthly magazine. She spent a year and a half with me in the work that we're doing at the Penn Museum, just interviewing all kinds of people. And my partner, Mariana Evans at Penn, where we, took all the scans. And this story just was released like 4 days ago, and it's already gone viral. She called me, she emailed me this morning and said the story is globally viral. So you can look it up. It's like why our skulls are out evolving us or something. I can read you the title, but it's an amazing description of what it is. I'm sorry?
Yeah, for listeners and for myself, if we can provide a link to the article or the title of it, that would be great. This is the note.
Yeah, well, I got it right here. So anyway, but that is certainly one aspect. We've published several textbook chapters in medical textbooks about how this is an adjunctive or primary intervention for kids who have sleep-related breathing disorders. We call it SRBDs. Sleep apnea is the worst case scenario. That's kind of end stage. So we want to recognize these signs. And then what we say is there's comorbidity of certain malocclusion traits with sleep disorder breathing. So that's kind of how it is getting into the cyberspace. I mean, there's some parents come in here and they already know about it. So when I first started doing this, it was kind of tough, and a lot of orthodontists were really, you're too early and you're not an orthodontist, and really disparaging, the work that I was doing even before I understood the implications of neurological development. I was helping kids because malocclusion, if you recognize it in a 3 or a 4-year-old, it will persist. That's lots of literature in the orthodontic literature that says when you see kids with narrow and retrusive jaws in the baby teeth, it will persist and it will worsen. And it even, before they understood that it had airway and neurological implications. So it's like to tell a parent of a 4-year-old that has, these indications for treatment, save up your money for braces, is like an ophthalmologist telling a parent, that your kid, your nearsighted 4-year-old, wait till they're driving a car because you don't want to burn them out on wearing too many glasses. And that's the argument that orthodontists put forward is that they say you'll burn them out. And it's like nonsense. It's medically indefensible to tell somebody to wait any more than you would for glasses or, a kid with high blood sugar. Would you ever say wait till your kid's old enough to use an insulin pump and maybe read Braille?
So they're afraid of they're afraid of what if the parents don't wait?
I'm sorry?
What are they afraid of? Why are they telling parents to wait?
Well, because they're not adequately prepared to deal with, like, how can I get an impression on a 3-year-old that won't open his mouth? They're fearful of, the resistance that they may get from a public that expects orthodontic treatment, in 10 or 11 years old, and possible, I'm a pediatric dentist. A kid who won't open his mouth, that doesn't bother me at all. I just leave the room. You don't have to open your mouth, but invite me back if you decide to do it. And I just leave the room. And then probably 95% of the time, the kid will be showing off that he can open like an alligator because my staff says, they just talk to him, and I leave the room. The kid can't wait to show me how big they can. That's just a little pedo trick, pediatric dentistry. But orthodontists don't learn that, and they can. It's not their fault, actually. I'm not really blaming the orthodontists. Their curriculum is at fault. They do not have any guidelines by which they have to demonstrate competence in managing anxiety in a child and managing expectations of the parent. That is pediatric dentistry 101. Every pediatric dentist knows how to do that.
Let's get somewhat into the science of it. So just basically malocclusion is what? What does that look like and what does it do?
Well, what it means is it's suboptimal alignment of the teeth and jaws with one another, okay? And basically, the earliest classification system is called the angle classification system, and Edward Hartley Angle in the late 1800s came up with a system by which you could show that the lower jaw was growing too much and the upper jaw not enough. The upper jaw was growing too much and the lower jaw not enough. And then just right, the upper and lower jaw were growing just right. That's angle class 1. Angle class 2 is when the, chinless, that the lower jaw is way too far back. And underbite, Jay Leno, he's a class 3. Those are extremes. Well, what we've discovered in our analysis of the museum specimens is that everybody on the planet except royalty, and I don't know if there's time to go into why they're an outlier, but pretty much everyone that survived, birth, because even in early childhood, wide jaws, forward jaws, and not long face jaws. There's 3 dimensions to how a malocclusion manifests itself. And one is front to back, one is width, and then the other one is vertical, or is the jaw growing long face, like Abe Lincoln. That's a sign of bad breathing early in life. So does that make sense?
So when this happens, all right, so just to be clear, when you say bad breathing, that means that the person will breathe through their mouth instead of their nose, and that will do what?
How often should you breathe through your mouth? Do you have any idea?
It's only when you're exercising, supposedly, right?
No, you should. Marathoners, Kenyan marathon runners, they run the entire race with their lips closed. No, you should.
Oh, wow.
You should breathe through your mouth as often as you eat through your nose, and that is something they make up. Karen O'Rourke is a family dentist in Grand Rapids, Michigan, and she came up with that. I want to make a poster of it and put it in my office. But no, we are designed by natural selection to be habitual nose breathers. And the only time that your tongue should not be in the roof of your mouth is when you're eating. Mouth breathers also, they have their tongue in their lower jaw, and it's growing the lower jaw. You need your tongue to be up in the roof of your mouth to grow your upper jaw, and then the lower jaw will follow it. So,
quick question: why do you need your tongue in the in your against your hard palate in order to grow your upper jaw? Is that because the tongue is pushing on the upper jaw slowly?
Well, pushing and widening, and what we say is whenever there's a conflict between muscle, and tongue is a group of muscles, and bone, which your jaws are. Whenever there's a conflict between muscle and bone will always yield. So that means when a baby's born and starts to suckle and then starts to wean on hard foods, and then those other things I talked about, click speaking and papoose, riding the in the mom's back, that tongue is up and forward and just pushing. The same way the brain grows. Do you have kids?
Yeah, I have 3, yeah.
Okay, so when they're born, they have soft spots on their head, right? Those are called fontanelles. They're sutures, and as the brain grows, those sutures allow the brain to expand, and the skull bone, appositional bone growth, it's called, will form, and then eventually, when the brain is done growing, it ossifies, or it forms hard bone there. Well, you got them all over the place, and like lick your tongue on the roof of your mouth. That's your mid-palatal suture. That's a fontanelle. You have one between your canines and your laterals called the incisive suture. As a baby's growing, and when they're nursing and weaning, their tongue, a group of muscles, is getting off the back of the throat and pushing forward, opening up the airway, expanding the face and the jaws, and that's really what needs to happen as early in life as possible. We have a thing. Our goal is to create an anatomy of the craniofacial respiratory complex that's conducive to habitual nose breathing during wakefulness and sleep for a lifetime. And that really is conducive to longer life and better life, quality of life and quantity of life. So, and again, we thought maybe we were one of the earlier developers of this hypothesis. Like 10, 12 years ago, Dr. Steve Sheldon, who is head of sleep medicine at Lurie Children's, he and I worked on this protocol together. And then it's only been in the last 2 or 3 years where we've discovered all this literature that there's nothing new under the sun. They were doing this between 1880 and 1940. Go figure. For 60 years, physicians and dentists were doing this almost exact protocol that we do. And I'd be happy to.
What is the protocol?
Well, it's what they called, and they weren't called ENTs, they were called rhinologists. And early on, before, the first specialty in dentistry actually was orthodontics, but orthodontics was being practiced as an art and science intervention by physicians and, general dentists all the way up until the early 1900s. In fact, there were some medical schools that actually had a curriculum in orthodontics for medical students because of the benefits to the nasal-respiratory function. So, I'm sorry, what was your question?
You mentioned a protocol that was done between 1880 and 1940. What was it? What is it?
Yeah, expansion of the upper and lower jaws, and what's called myofunctional therapy, which is getting the tongue upward and forward. Myofunctional therapy is being. I just was at a conference recently, the World Sleep Society in Vancouver, where I was a speaker, and there was people talking about myofunctional therapy as being an emerging new intervention. It's not new. It's being renewed. But this myofunctional therapy was understood in the late 19th century, all the way up through, again, pre-World War II, and it's now being rediscovered. So, this is a new era. And again, the American Dental Association is getting completely behind this. When the House of Delegates actually passes a resolution, that means a funding source is going to begin. And dentistry is going to lead the way in this, and start collaborating more with medicine and not just taking out tonsils and adenoids. This can work with doing tonsils and adenoids, or it can, some people suggest, and not me, that it, can be done instead of. I like to introduce it as an adjunctive, that there's a high rate of failure of TNA surgery to cure sleep apnea. Like 2/3 to 3/4 of kids will have recurrent symptoms after a tonsil and adenoid surgery. Well, if you're expanding and protracting, the jaws, it stands to reason that there's going to be more room, for air. When you take out adenoids and tonsils, you're relieving one obstruction, but there's still, if the face is too retrusive or too far back, there's still going to be crowding of that airway. So that answer you?
So, all right, you like way early on, you mentioned a 7-year-old as being a geriatric patient in the pediatric dentistry world. A lot of people listening to this, myself included, will have kids, 8, 10, 12. What can be done to help them if they have malocclusion, if they have sleeping issues, etc.? Can myofunctional therapy work? What can be done?
Yep. Myofunctional therapy and expansion can work in adults. I don't treat adults, but Mariana Evans does. She treats kids and adults. And the type of expansion and protraction orthodontics that she does, it looks like they've had jaw surgery. It's just unbelievable. So, in the right hands, this can, I say I'd rather treat a kid at 2, 3, 4 years old. But if somebody brings a 9-year-old to me, are we too late? No, 9 is great. I'd rather have them at 9 than 13. It's all relative. For me, it's at the earliest age as is feasible. Well, as a pediatric dentist, I'm seeing kids at 1. I'm not doing ortho on them, but I'm doing, recommending baby-led weaning and myofunctional therapy. But the earliest age as is feasible is when I see a kid. So if a 12-year-old moves here from Seattle, 12 years old is the earliest age feasible. But, again, ideally, and even I can, I'll send you a paper from JAMA, Journal of the American Medical Association, 1922, 30 months of age.
Well, that'd be great. That'd be great.
30 months of age is the ideal, most optimal age to start treating a kid who has a narrow upper jaw and breathing problems. So,
what does it look like, for instance? Like, just quickly, what are the mechanics of an example treatment for, a child, let's say 2.5 years old? Literally, what would be done with them? To the layperson, how would you explain it?
I had a 2.5-year-old today referred to me, and this child, are you ready for this, was born 4 months premature and weighed 20 ounces at birth. So that kid's not ready because there's all kinds of behavioral problems. I mean, orally intubated in intensive care for 4 months, so that the palate is completely underdeveloped. But what I want to do is just shape their behavior. So that's one extreme. Most 2.5-year-olds, 3-year-olds, once their oral defensiveness is something that you can deal with. And again, I'm a pediatric dentist. I know how to do this. I can get in there and do something like there's things called MyoBrace and MyoMunchies and infant trainers. They're little rubber or plastic devices that I use them to just get kids less orally defensive until I can get an expander in there, or what's called an alpha plant, capital A, capital L, capital F, or just a palate spreader is what 100 years ago, that's what they called them. And these kids tolerate them great. It's the best kept secret in orthodontics. These kids are amazing. I take a 3-year-old over a 13-year-old boy any day of the week, because I used to be one of those. And 13-year-old boys are nice kids, but the worst in compliance with orthodontia. Little kids under the I've got a really good team of assistants, and they all love kids, and I can leave the room and they can get a kid. They can get a 4.8 second cone beam scan, the X-ray on a 3.5-year-old, 6-year-old with Down syndrome, and they're not always perfect, but I can get really good diagnostic images. And it's not me; it's my team. That's what's really important. If you're ever, you don't want to give away where you live, maybe, but if you
I'm in Austin, Texas, but
Austin,
that could be anywhere.
I've already
I'm in a secret location in Austin, Texas.
I can refer you to somebody great in Austin who knows what they're doing relative.
Yeah, please, actually, afterwards, sure.
Yeah. So no, and we're establishing people all over the world now. Today I had a dentist from Maine. Every day I have people shadowing me that hear me lecture and want to come and learn our protocol. So,
quick question here. All right, so a big thing that's done to children is braces. So tell me what your thoughts are on braces and your experience. Good, bad, horrible? What do you think?
Well, braces implies brackets, right? So there's a time and a place for brackets, but a lot of what we do doesn't really involve brackets. I mean, sometimes what I'll do is widen the kid's upper jaw, and their front teeth go from being crowded and crooked to having too much space. Well, then I put 4 what I call temporary braces on an 8-year-old, say, and I pull those spaces together and close it, not for cosmetic reasons, even though it does look better. It redistributes the space to the upper canines to where they previously were blocked out. And now there's plenty of room. When you have blocked out canines, that means that there's not enough room for the tongue. And if I look at a Panorex of a 3-year-old, and incidentally, it's safe, not over radiating kids, it's very low radiation, and the image quality that we get relative to the low radiation in a 4.8 second cone beam X-ray is fantastic. It really helps, and it shows the parents that the upper canines, there's no room. The teeth are already touching that they have to fit between. Well, a lot of orthodontists say, well, that canine doesn't come until 12, so why don't you wait till they're 10 or 11 and then we'll start treatment and maybe have to pull some teeth, but you don't have to pay for braces twice then. It doesn't work that way. When you expand a kid really early and then you have to go back in and do Invisalign when they're 12, it doesn't mean you're doing anything over. You're doing some things additional, but you've got a kid that's, to be able to breathe through their nose at the maximum development of brain development, where they actually need the best oxygen and the best sleep. So I use temporary braces on little kids. We don't really do full teenage braces much anymore. We do Invisalign because that technology has really gotten way sophisticated. We can even, do it on kids who don't have all their permanent teeth in yet. So I'm not promoting Invisalign. I'm just saying that we don't have to do a lot of the stuff that full metal mouth anymore.
Well, what do full braces do? The look is they straighten the teeth and all that, but what's the good and the bad of them? Are they fine? Is there a better way?
No, if you got an older kid or younger kid that eats a lot of sugar and doesn't brush their teeth, you can get white spots and even bad tooth decay around the braces. So they have to have extra cleanings, and wires can come out, poke them, but we're used to dealing with that. We help parents anticipate what the problems can be and how they can manage some of them of their own. If there's emergencies, we're on call 24/7. I'm also an attending in a pediatric dentistry residency in Chicago. So, I have residents that can manage emergencies if they have to. I don't utilize that very much. I like to take care of my own emergencies. I make house calls. People can bring their kid over to my house. I keep a full emergency kit at home. But Invisalign, you don't have those issues, but you have compliance issues. They got to wear them, the aligners. And do you know what Invisalign is? You heard of it?
Yeah. Yep.
Yeah.
Yep.
So it moves teeth orthodontically without wires and brackets on the teeth. So
it looks to be like a hard, clear retainer for the top and bottom teeth, right?
Yeah, that's what Invisalign is. But they're you have a series of them, and each, every 2 weeks you put a new aligner in, and it moves teeth gradually the same way braces. So.
Oh, okay. So it's a progressive series of retainer-like.
Yes.
Well, of retainers essentially that slowly move the teeth in a given way.
So listen, the name of the article is called "Our Skulls Are Out-Evolving Us." I didn't make that title up, by the way. And that could mean a public health crisis. Is that the name of the article? Let me see. Our skulls are out-evolving us. I think if you just Google that, and the name of the magazine again is Medium. And oh my God, she's a great writer, Catherine Lewis, and she did a great job on this. I've just gotten so many great comments from, colleagues about it. And I emailed her this morning. I said, how is this resonating in the journalism realm? And she said, it's internationally viral right now, literally.
That's great.
It's a good summation of our research and what we're talking about here. Is that the premise is basically all humans genomically are equipped, depending on the environment from probably before birth and early childhood, to have all of their teeth in, even their wisdom teeth. That I don't make that a treatment goal, but that's nobody had impacted wisdom teeth really till the Industrial Revolution. So that's when you're treating, like I'm treating little kids, and I have the knowledge that this kid sitting in my chair, even though the roof of the mouth is high and the teeth are crowded, even though they're baby teeth, they're still not enough room. I'm confident that because I know that kid has the genomic potential to have room for his tongue. That's the whole conversation has changed. We're doing everything to create tongue space. That's really what we're doing. And when you do that, when there's room for the tongue, there's always room for the teeth. And it's true. I mean, I've got thousands of examples for that support why I'm saying it's true. And I've been doing orthodontics for about 30 years now, and I've got kids that are 10, 15 years out of treatment even before I understood airway.
So what are some of the major warning signs to parents that something's wrong with their child, maybe sleep-wise or otherwise, and what gets fixed with this therapy?
Inattention, and again, this goes back to the 100-year-old literature that kids who have retrusive jaws can be accused of inattention by teachers. This is over 100 years ago that was being talked about. Wetting the bed, grinding the teeth, snoring, sleeping with the mouth open, moving around in bed, sweating, nightmares, night terrors. Those are all validated behavior traits that kids who have sleep and breathing disorders will have. It comes from, and I can send you this too if you'd like. It's called the Pediatric Sleep Questionnaire, which is a series of 24 validated questions to, correlating certain behaviors to poor sleep quality. And then there's something called an overnight sleep study, a polysomnogram, that they're expensive, but that's the only way you can define apnea. That means holding your breath while you sleep. In a child, you can't really give a diagnosis of apnea unless they have an overnight sleep study. Well, if I do a pediatric sleep questionnaire and then combine it with a physical risk assessment of the craniofacial respiratory complex, and I actually am authoring an assessment tool called Chicago Hearts. It's an acronym. C stands for crowding, H stands for hypertrophy of the tonsils. So incompetent lips is I. But and it's really, we hand it out to physicians. It's a little flip chart, and they can look at a kid, and these are all traits, physical traits that correlate with either existing airway disease or predictive of future susceptibilty. And I'll send you a PowerPoint of Chicago Hearts if you want it. I hope you're writing this down and you send me a list of the things I promised you, and I'll try to make good on it.
Yeah, there's a lot. I've got a lot of homework to do now, but this is good stuff.
Well, if you got kids, you're going to want to do it because, I can tell by the way.
Oh, I agree.
You might be concerned about somebody you know and love, so I'd be glad to help you. I mean, call me after this or email me, and I'll try to put you in touch with somebody locally, or if you're ever in Chicago.
Okay. Well, that's great. Well, I want to give the resources to listeners too. So I'm going to ask you, and then we're going to include as much as we can in the show notes. And then for listeners now, because we're ending, what general things can they look for if they have children that have issues, and maybe perhaps themselves as adults, they have issues? How can they find a dentist that will be aware of these therapies instead of just the standard?
There is talks of establishing a network that people can go to. There's lots of people for adults, but not many for kids yet. There will be. So I would say, if somebody like a parent or grandparent, aunt or uncle, has sleep apnea, well, right away you can suspect there might be familial or genetic predisposition. So the questions you would ask yourself or somebody else is, does your child snore? That's the first one. And pediatricians are all supposed to be asking this: does your child snore? And if the answer is yes, how frequently and how loudly? A survey has been done, and only 12% of pediatricians ask that first question. And of those 12%, 0 of them asked the second question. So the Academy of Pediatric Medicine came out with this guideline, maybe 8-10 years ago. Pediatric sleep apnea has only been defined since 1976. Christian Guilleminault, he's at Stanford, a French pediatrician who, he's the one who discovered it. He died recently, but it's still, even though it's been discovered since 1976, there's still not enough people. Oh, kids can get apnea? Yeah, they can. But the snoring question, do they sleep with their mouth open? Are they difficult to wake in the morning? Those are, do they sweat? in their sleep? Those are, there's 3 or 4 basic questions that people can ask. And if those, any combination of those, especially snoring, you got to take it to another level. And most orthodontists really don't want to see a kid till they're 7 or older. Sorry, that's just the way it is. Some do, not all of them, but the vast majority of them just think that it's superfluous to look at a kid before that age, and certainly you wouldn't do anything. And most pediatric dentists, even though they understand growth and development, they're not really aggressive on treating things beyond maybe cross bites, which is an underbite in the back or front, which is good. But there was a airway symposium. The ADA sponsored it 2 years ago, and the orthodontist showed up, the otolaryngologist showed up, the myofunctional therapist showed up, the pediatrician showed up, speech pathologist showed up, sleep medicine people showed up. It was a big roundtable. It was a huge deal. The Academy of Pediatric Dentistry declined. Thanks, but no thanks. There's not enough evidence. Was their contention. But I think there's the evidence has become much more clear, and I really think that subsequent roundtable events and symposia that we're going to have on this, the pediatric dentists will be there. And we're hoping this influences curriculum change. The pediatric dentists and orthodontists are going to be learning more about this in their training.
Very good. Well, Dr. Boyd, it's been a great call. We got some resources coming for listeners, and I appreciate you being on the podcast.
And, give people my email if they want to email me.
What is it?
And if they're dentists, it's K as in Kevin, B as in boy, O as in orange, the number 569@gmail.com. And really, if any clinician out there is in Chicago and wants to shadow and, for a half a day or whatever, we welcome it. We don't charge any money for it. We just, we want to get this out there and get other people doing it. It's not that difficult, believe me.
Okay.
Great. Thanks for having me. I
very good.
appreciate the opportunity.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.